Hello all, good morning. I'm Dr. Doris. I'm Assistant Professor of Anatomy at the Government Medical College Thiruvananthapuram in Kerala in India. At the outset, let me thank the organizers of the CME who have kindly invited me to this continuing neurological education program at Surabaya. My job here is to give you a basic outline about the cerebrovascular system development. Okay. Uh, I hope this will give you some insight when you come across variants in your clinical practice during your interventional radiology or interventional neurology. So let us go into the topic. I have designed my topic in this outline. First, I'll be dealing with the basics of brain development. Then I'll go to the topic called intracranial vasculogenesis, which is a little bit lengthy. So this will be the first segment of my presentation, and then I'll quickly rush through the different variants that you might encounter in your practice. And this includes fenestrations and duplications, then circle of Willis anomalies. Then I'll go through the normal arterial variants, the ones that you can also see in the skull base. And I'll also go through an interesting series called carotid basilar anastomosis, which has four types: trigeminal, otic, hypoglossal, and proatlantic. Okay, we'll go through these in that chronological order. So first, I'll go to the brain development part. Brain develops from the neural tube. If you look at this neural tube, this is the cranial part and this is the caudal part. The caudal part retains its tubular structure, and that is called the spinal cord. The cranial part develops a series of bulges, and they are called the cranial vesicles or the brain vesicles or the three-part brain. Okay, this is found typically in the late third to the fourth week. Okay, late third to the fourth week. So the first one is called the prosencephalon, which is called forebrain. Next is called the mesencephalon, also called midbrain, and the third is called hindbrain, which is called rhombencephalon. Okay, so this is prosencephalon, mesencephalon, and this is called rhombencephalon. The prosencephalon further divides. You can see that in the third month it develops into a five-part brain. The prosencephalon further develops into a telencephalon and a diencephalon. So initially you have prosencephalon bubbles, it develops into two telencephalic vesicles and a diencephalon in between it. Diencephalon will be sandwiched by the two telencephalic vesicles. The telencephalon is developing into cerebral hemispheres and diencephalon will be sandwiched. You can see that the telencephalon is overgrowing the diencephalon. You cannot see the diencephalon when you look from the outside. Telencephalon becomes so massive, and you can see that in the brain. When you see brain anatomy specimen, you can see that the telencephalon has overgrown into the whole cerebrum. Okay. And the mesencephalon remains like that. There is no further subdivision. The hindbrain develops into a cranial metencephalon and a caudal myelencephalon. The cranial metencephalon will form the pons anteriorly and the cerebellum posteriorly. Okay, but both of them are derivatives of the metencephalon. Metencephalon is the cranial part of the rhombencephalon, and myelencephalon is the caudal part of the rhombencephalon. I know that many of you may get confused with the encephalon part, but I hope you got the rough idea of how the adult brain is architecture is arranged. Okay. With that understanding, we'll go to the intracranial vasculogenesis. Okay, so this is the dorsal aorta. This is the ventral aorta. The ventral aorta will be connected to the dorsal aorta by a series of arterial arches, and they are called arterial arches or arch arteries, because they will be traversing through pharyngeal arches. Okay, so you will have a ventral aorta here, you will have dorsal aorta here, they will be connected by arterial arches. This is the first arch. Okay, first arch will be regressing. This is the second arch that will also be regressing. Third arch is going to remain, and this is the dorsal aorta. You can see the dorsal aorta here. The dorsal aorta is giving off a cranial extension. That cranial extension is the one that is going to supply the brain. Before this 1 month, the brain was supplied by simple diffusion. But as the brain is getting increased in its volume, in its biomass, the neuronal volume is going on increasing. The brain needs a dedicated blood supply. That's when the branch from the dorsal aorta will shoot up to dedicated for the supply of that brain tissue. Okay, so it is basically an extension of the dorsal aorta. So if someone asks you what is the internal carotid artery developing from, it is developing from the third arterial arch in the proximal part, and in the distal part it is an extension of the dorsal aorta. Okay, you can look at this part too. This is the fourth arch. Fourth arch artery is going to develop into the aortic arch. I mean the arch of the aorta. So this is the arch of the aorta continuing as the dorsal aorta, and actually this much part is going to be regressed. Okay, so that is the basic idea of development. You should understand that the internal carotid is the primary artery. It is going to be the primary artery that is going to supply the brain. I'm going to more details of that. So you can see that internal carotid artery is the one that you are seeing here. This is the ventral aorta. This is the dorsal aorta. I mentioned that already. Dorsal aorta is extending as the internal, shooting up to supply the brain. Okay, and you can see that this is the from the ventral aorta. You can see the third aortic arch, AA3, arterial arch, the arch artery 3. So the arch artery 3. This is going to be internal carotid artery. So that is the internal carotid artery, and you have, it will be good if you look at a very interesting, a very peculiar another longitudinal vessel. Okay, this is another longitudinal vessel, and this is called longitudinal neural artery. And I want you to look at the brain at this point. This is undoubtedly the prosencephalon or the forebrain. This is the mesencephalon. Mesencephalon characteristically has a bend. Okay, mesencephalon has a bend. You call it the mesencephalic flexure. Okay, that is a mesencephalic bend, and this is the rhombencephalon. So the longitudinal neural artery is located ventral to the rhombencephalon. Okay, the rhombencephalon ventral. Rhombencephalon is the hindbrain, and you know that rhombencephalon develops into pons anteriorly, cerebellum posteriorly, and the medulla caudally. So ventral to those, you have the longitudinal neural artery. Why I said all this is because being very familiar with the adult anatomy, you can obviously understand that longitudinal neural artery is going to be the precursor of the vertebrobasilar system or the posterior circulation. But one interesting point here is that here you don't have the vertebral artery. There is no vertebral artery now. You only have the internal carotid artery. So the internal carotid artery, as I mentioned in the previous slide, internal carotid artery is primarily supplying the brain. That's why I stated that statement initially. So the internal carotid artery is going to supply through the longitudinal neural system, okay, through these series of vessels. Okay, let us have a look at that. Okay, I'm going to let me just erase these off for more clarity. Okay, okay, and so you can see. Can you see this vessel? Can you see this vessel? This vessel is the trigeminal artery. Okay, and this is the otic vesicle. Otic vesicle is nothing, it is an internal ear apparatus. It is in the adult, it is the it develops into the otic capsule, which further develops into the inner ear. So everything is located within the petrous bone. So around that you have a series of small vessels, and that is called the otic vessels. And here you have the hypoglossal vessel, and here you have the first cervical intersegmental artery, which is called the pro-Atlantic artery. So why are these arteries? What is the importance of all these arteries? These arteries, they are actually channels that is communicating the longitudinal neural system that I mentioned already with the carotid system. So the carotid system is going to perfuse the hindbrain through these series of vessels. Which are the series of vessels? Trigeminal, otic, hypoglossal, and the pro-Atlantic arteries. And you can see the on further development, you can see that this longitudinal neural system is now gaining access. The blood supply is being now perfused by the vertebral artery. So vertebral artery comes only later in the embryology. Vertebral artery, you know, it is developing from the subclavian. This is subclavian artery. So subclavian artery, you have a lot of intersegmental arteries. Intersegmental arteries will have a series of longitudinal anastomosis, and all those are longitudinal anastomosis gets connected, and the main trunks gets deleted off, and that forms the vertebral artery. And the vertebral artery gets connected to the longitudinal neural system. You know that this is, I mentioned that this is the first cervical intersegmental. So first cervical intersegmental distal part remains as the horizontal suboccipital part of the vertebral artery. That is the V3 segment of the vertebral artery, and that continues as the vertebral artery and into the basilar artery. So that is when the longitudinal nervous system gets its blood supply from the vertebral artery. Till then, it is by the carotids. Now let us look that these vessels, this is the third arch. I mentioned that already, third arch continuing as the internal carotid. This is the arch of the aorta. This is the subclavian, the seventh intersegmental, cervical intersegmental, and this is the longitudinal anastomosis between all the intersegmental arteries that is going to form the vertebral artery. Now let us look at some interesting points over here. This is the longitudinal neural artery that I mentioned earlier. This is the internal carotid connected by trigeminal, hypoglossal and pro-atlantic, already mentioned. Internal carotid divides into a cranial ramus and a caudal ramus. Caudal ramus is what I have written here. Cranial ramus is called the olfactory artery. Olfactory artery. Olfactory artery is the precursor of the ACA. Actually, olfactory artery further divides into medial olfactory artery. Medial olfactory artery is the precursor of the ACA, and ACA is the first artery, the most primitive artery to be developed in the telencephalon. Okay. So ACA, all the other arteries including the MCA, PCA are all latecomers. Along with this ACA, you have another artery from the cranial ramus that is called the anterior choroidal. So the olfactory artery and the anterior choroidal are going to balance the blood supply towards the telencephalon at the initial point. Okay. The caudal ramus is actually the precursor of the PCOM. Let us look at further what are the fates of these. Okay. The medial olfactory is going to develop into ACA. The lateral olfactory, this is the lateral olfactory. Lateral olfactory is going to develop into the MCA and all the perforators of the MCA and the ACA. That means the Huebner, the lateral striate, and MCA all are actually developing from the lateral olfactory. Okay, I mentioned that this is the olfactory artery. Olfactory artery develops into medial and lateral. Olfactory artery develops into medial and lateral. The medial one is the ACA. The lateral one develops into the Huebner, the lateral perforators, and the MCA. MCA is actually gaining cortical territory. If you look at the evolutionary perspective and the embryology perspective, MCA is actually a very late comer. MCA is actually one of the late perforators of the ACA that got a cortical supply. Okay, so that is much more lateral. That's why MCA is located more lateral, because it is developed from the lateral olfactory branch. Okay, so this is the anterior choroidal. Anterior choroidal is substantial because choroidal tissue is giving a substantial biomass for the developing brain. And this is the PCOM. I told you that is developing into the PCOM, from where you can see the posterior choroidal artery. This is the posterior choroidal artery, and this is the midbrain. Okay, this is the midbrain. So this is the tectal artery. The tectal artery is going to develop into the true posterior cerebral arteries. Okay, posterior cerebral artery is developing from the tectal artery. You may wonder, how can a midbrain artery be developing into posterior cerebral artery? You understand that telencephalon is going to be so massive. It is going to be so massive. So the tectal artery is going to annex and gain the supply of the posterior cerebral artery. So all of these are important. So actually, the PCOM, the basal tip of the basilar, and the tectal artery, and even the superior cerebellar artery, okay, that much are actually developing from the carotid system, and this much lower part is actually developing from the vertebral system. Okay, development wise. But in adult pattern, you already know that the posterior circulation goes and supplies till the basilar, the posterior cerebral, the posterior choroidal, everything is supplied by the basal. Why this occurs? Till here the blood supply is going in this direction. Okay, till here the blood supply is going in this direction. We call it craniofugal. But as the vertebral artery gains access, the blood supply is going backwards. Okay, the blood supply going backwards in the basilar. You know that vertebral joints to supply the basilar. That is actually a late developmental event in evolutionary also, and in embryology also. You know that ontogeny recapitulates phylogeny. Okay, now if you look at a ventral view of the brain, you can see that this is the olfactory branch. This is the medial olfactory branch. Medial olfactory branch is going to develop into the ACA, and you can see a development of a plexus. Here you have actually a plexus. Okay. and the lateral ones is the MCA. Okay, this is actually the lateral olfactory. You will have the striate branches. All of these are developing from the lateral olfactory. These are the longitudinal neural arteries that you find on the ventral aspect of the hind brain, and these longitudinal neural arteries are going to fuse together. Okay, they are going to fuse together, and that is going to form the basilar artery cranially and the vertebral artery caudally. You can see that the unfused part will form the vertebral artery and the fused part will form basilar artery. Deficits in this fusion will eventually cause fenestrations or duplications can be seen. Now this is a pictorial summary. You can see that this is the internal carotid developing into this is the cranial ramus and this is the caudal ramus. Caudal ramus is becoming the PCOM. Okay, so this will be the P1 this will be the P1 segment, and this is the posterior choroidal. This will be the PCA. See, the PCA is eventually the tectal branch is becoming the PCA, and you can see the MCA also developing. So the PCA and MCA are late comers. Why they are developing late? They are developing late because only after the vertebral artery gains access into the longitudinal neural system, the longitudinal neural system is relieved from the carotid system. That is called the vertebrobasilar relief. Okay, vertebrobasilar relief. Vertebrobasilar relief is the trigger for the development, enormous development of the MCA and the PCA territories. So you can see that the first branch that is developing in the ACA, that's why I said ACA is the most primitive vessel if you look at evolution or at embryology. Okay, so this is the PCA and this is the superior cerebellar artery. Till the superior cerebellar artery, that developmentally it is arising from the anterior or the carotid system. Okay, carotid system, caudal ramus. The caudal ramus, that vessel is actually going to contribute into the formation of PCA, P1 and up to the superior cerebellar. Okay, technically speaking, you remember that this is the trigeminal, this is otic, this is hypoglossal and this is pro-Atlantic. The part proximal to the trigeminal is embryologically part of the carotid system. But further, after the gain of the vertebral blood supply into this, the blood supply, when the blood supply turned backwards, all this has become the posterior circulation. I hope you understood how the posterior circulation was gained by the vertebral artery when the vertebral artery joined the longitudinal neural system, and actually the posterior cerebral, superior cerebellar, P1, basilar tip, everything was conquered by the vertebral arterial system. I hope that point is clear. Now we'll quickly go through the variants. Okay. The normal pattern in that plexus, it is a very complicated plexus, but this is the final normal pattern and all the other ones have been regressed. So it is very simple to understand that this is A1 segment, this is A2 segment and this is the ACOM. And this is the ICA dividing into the MCA and the ACA. Okay, so this is actually the normal pattern, and this is actually a single variant of the normal theme. Okay, so let us look at what are the other possibilities. There are a lot of possibilities. One is called the duplication and the fenestration of the AC and ACOM. You can see a duplication of the ACA. You can see another duplication of the ACOM here. ACOM duplication is defined as two individual channels that are connecting the two ACAs. You can also see another peculiar entity called fenestration. Fenestration, you have a single limb connecting to one ACA and it has a Y formation, and that Y limbs will be connected to the next ACA. This is called a fenestration. So fenestration can predispose to more aneurysm formation. If you look at this with this plexus formation, all this are basically different permutations or combinations of this basic theme. If you look at this, this is basically the fenestration is looking like this, right? Like this. This will be the Y, okay, and this will be the ACA. Okay, so that is a pattern of a fenestration. A duplication will be something like this. Okay, two ACOMs. So all this is possible. You can have to just draw through this maze to get different patterns for these variations. Fenestration of basilar and vertebral is also common. Many studies say that posterior circulation fenestrations are more common. Around it is 5 to 7%. Now, fenestration of basilar and vertebral, it can occur due to deficits in the fusion. I told that it fuses like a zip. So if that zip fusion is not possible, you know that when you open and close zips, you can have defects. So just like that, you can have an open bubble, and that's exactly what you see here. The basilar fenestration can be seen here. A vertebral artery fenestration can be also be seen here. So they are all possibilities when the longitudinal neural systems are not fusing in the ventral aspect of the hindbrain. Now, circle of Willis variants are also common, and the most common one that everyone knows is the fetal PCOM or the fetal PCA. And this again, it is called fetal because you already know that I mentioned that in my in that earlier picture that actually the tactile artery. If I clear this off, this is the tactile artery. Tactile artery is actually developing from the carotid. This is the reason why it is called fetal PCOM or the fetal PCA. Tactile artery is going to develop into the PCA. So the PCA was embryologically part of the carotid system. And if the PCOM was sufficiently large, then the carotid is going to supply the PCA. So that is why it is called a fetal PCA or fetal PCOM. Okay, so it is found very commonly. It is around 20 to 30% is the incidence rate of it, and the reason is said to be that developmentally it is we have not yet completely evolved to hold the PCA into the posterior. So that may be the reason. The angiographic definition is that the PCOM caliber should be greater than the P1 segment caliber. Okay, so why that has occurred? This side, the vertebral artery circulation has not completely conquered the PCA circulation from the carotid circulation. That's why it is called a fetal PCA. Okay. Now you also have unpaired ACA. Okay, I'm sorry, unpaired ACA, also called azygos ACA. What is that? Again, from this pattern, you can see in the midline you have something called the artery to the corpus callosum, median artery to the corpus callosum. I didn't mention that in the midline. In spite of these two arteries, you have a median artery to the corpus callosum, and if that artery alone is persisting with regression of these two arteries, it is called an unpaired azygos ACA. There are speculations that this is the future of human evolution. That you will have in future generations, the Homo sapiens will evolve to have a single azygos. It's one of the postulates. Okay, it's not completely proven. And another one is that you can have a bihemispheric ACA. It's almost similar. It's the only difference is that you have ACAs on both sides, but one side it is very much hypoplastic, and the larger one is going to give off one more branch, which is going to supply both hemispheres. The clinical standpoint, both of these are significant because a single ACA is going to supply. Okay, even this ACA or this ACA is going to supply both the ACA territories of the medial part of the cerebrum. Another one is the median artery of the corpus callosum persistence, also called the triplicated ACA or the triple ACA or the accessory ACA, in which all the three vessels are present. The median artery to the corpus callosum and both the ACAs are present. Okay, the incidence is said to be very high in neonatal autopsies and 22% in adult autopsies. So probably this vessel has not been sufficiently regressed in these variants. You also have something called duplicated and accessory MCA. These are only terminological definition wise differences. Let us look at what these two things are. If you look at these basic theme from the internal carotid termination, you know that usually the internal carotid terminates into MCA and ACA, right? So from in here, internal carotid is giving off MCA and ACA, but one more MCA branch is being given. Okay, and that is called two vessels are originating from the distal end of ACA. That is called a duplication of MCA. So this is the characteristic duplication. Okay, and this side you can see that the internal carotid dividing into MCA and ACA, and from this ACA you can see another branch is given off, and that is called an accessory MCA. Now this definition is being given by T. et al. This is a working definition. So there are other definitions also if you look literature. But anyway, the importance is that this may be supplying the anterior. For example, this artery, the accessory MCA may be supplying the anterior frontal aspect, and then our frontal lobe. The duplicated MCA may be supplying the anterior temporal lobe. So that is why these all are important. Now, normal arteries can be variants can also be seen in the skull base. Prime importance, you have a very rare there is a very rare incidence of something called a hypoplasia or agenesis of ICA, But if you find something like this, an agenesis of ACA, it will be good if you take a bone window CT, in which you can see the carotid canal very clearly on one side, but if you compare with the opposite side, the carotid canal is very, very narrow. If you see this, it is a proof that it is not an atherosclerotic plaque that is occluding. It's not an acquired lesion, but this is a congenital lesion. Why this is important? Because only after the development of an artery, around that artery only a bone can develop. Okay, the arterial tree, around the arterial tree you have the connective tissue. Only within the connective tissue the bone will be developing. So uh, that understanding, that embryological insight will give you the idea that you need to take a bone window. So around the artery you will have the bone formation. So if the artery is small, the bone will also be small. The canal will also be small. You also have aberrant ICAs where the artery is seen now juxtaposing the middle ear cavity. You can also have lateral pharyngeal ICA, in which the ICA can be seen very on the posterior wall of the pharynx. Okay, this is also very important because here the ICS on this side and this side can be very close together, and if it is bilateral, it is called kissing carotids. And this is very important because normal pharyngeal procedures, pharyngoplasty or posterior pharyngeal procedures, tonsillectomy, everything, the carotids can be at risk in this case. Persistent fetal intracranial arteries, you have, I told you that you have trigeminal, otic, hypoglossal and proatlantal, and these can persist. These are the variant types called Salzmann types of a persistent trigeminal artery. You can see that this is the carotid. From this carotid you can see the trigeminal artery persisting, and this is the distal part of the basilar. Okay, so this will be characteristically seen from the cavernous part of the ICA. You also can have otic artery, but otic artery is now said to be non-existing because earlier in the picture itself I shown you they are very slender branches. So if it is present, it should course through the internal acoustic meatus. I told you that otic capsule is present within the petrous. So if by definition it should go through the internal acoustic meatus. A primitive hypoglossal should course through the hypoglossal canal. So this is a 3D rotational angiography in which you can see the hypoglossal canal, in which you can see the large hypoglossal artery traversing through it. This is again the volume rendered image in which you can see the internal carotid, you can see the basilar here, which is connected by the hypoglossal artery. Hypoglossal artery is connecting the cervical aspect, cervical part of the internal carotid to the basilar artery. Again, here you can have the regression of the vertebral artery. This is the persistent primitive proatlantal artery. Persistent primitive proatlantal artery. This is actually a hypoglossal. On this hypoglossal, they are showing how a persistent primitive proatlantal can occur. Okay, this is characteristically located in the space between the occiput and the atlas. Okay, because that is the first cervical intersegmental artery. So that will be the location of this proatlantal artery, because this is also the location where you have the horizontal segment of the vertebral artery. So that is the same location. So it will be connecting the internal carotid to the vertebral artery, and it will be passing through the foramen magnum. So the passage through the foramen magnum is the most essential criterion for defining the proatlantal artery. So altogether, summarizing, we learned about the basics of the brain development. We learned about intracranial vasculogenesis. We went through the different variants of fenestrations, duplications, circulovillus anomalies, normal arterial variants, and also the carotid basilar anastomosis, mainly trigeminal, hypoglossal, and proatlantal. We questioned the presence of otic artery. So thank you so much for inviting me into this talk, and I hope you have gained at least some insight from this presentation. This is my email ID, and this is a YouTube channel that I have where I have a lot of videos related to neurology, neuroanatomy, and I'll be uploading more and more content as time passes. Thank you.